So so you basically went like that, right?
Okay.
So, Aiden O'Connell, I know this was a few weeks ago.
Yes.
I'm just glad to have you on.
Sure.
Backup quarterback,
Right.
Raiders, Aiden O'Connell, and he went foosh.
Yeah.
What's a foosh?
Well, that's essentially, it stands for fall on an outstretched hand.
Foosh.
Right. And so what usually happens is when you fall like this, you're causing a hyperextension of the wrist and then basically an axial load as well. And that causes the fractures. Now, we don't know what type of fracture that he had, but the most common types of fractures that you get with a foosh injury is a fracture of the distal radius, which is this bone right here, or the scaphoid, the small bone right here. A small but extremely important bone. I call it the quarterback of the wrist, actually.
Ooh,
I
the backup quarterback may have had a quarterback injury.
Yeah, I tell that to all
right.
my patients because
Yeah.
it is one of the most important bones in the wrist, right? So.
And so before we get into the specifics about the distal radius or scaphoid fracture and all, just understanding the mechanism of injury.
Right.
So, you know, if you're landing, you could be at a different angle, right? You could be twisting.
Absolutely.
So you could have the axial, torsional in multiple planes, coronal, sagittal, planes as well. And you land, and then the muscle kinematics, the muscles are pulling and torsioning at different angles.
Absolutely.
And so it's a combination of, like, how much body weight of force do you think someone lands? Like, we're talking what? He's probably like, what, 180?
Oh, I guess he's probably over 200.
Over 200. So 200-pound
Right.
backup quarterback.
Yeah,
So,
I mean,
you know,
that's
and it goes like this.
And
So how many times body weight do you think that is?
I mean,
Several.
It's a lot, right? So, and then you have to take into account the speed at which
Right.
he is also going, right?
Right.
And
So deceleration, it's, you know, it's just simple physics, right? So you have this body hits ground, right? You've got lots of Newtonian physics happening. So you land, you twist, you pull, but you're also decelerating after you accelerate. So you get boom. Every action has a reaction. So you've got forces going down while forces are pushing up, and
yeah.
right?
Right. Exactly.
So let's start with, I know the scaphoid is the quarterback.
Exactly.
I love that. I love that. So let's start with the scaphoid. What is it about the scaphoid?
Yeah.
Is it the blood supply? Is it the type of bone? Is it the shape of the bone? What is it about the scaphoid that makes it so important?
All of the above. So basically, the scaphoid bone. Let me just go back to the injury part. But that when that hyperextension moment happens and you get that compressive load, the scaphoid shifts into this vertical position, and that's what causes the injury. It's more prone to injury at that point, right? And then the scaphoid has. We basically break it up into 4 different components. So there is the scaphoid tubercle, which is right down here, if you can see that. Then you have the proximal pole, then you have the waist, and then you have the distal pole. So those are the 4 different type of fracture patterns you can see. Now, the reason why, an orthopedic surgeon, hand surgeon would get very concerned about a scaphoid fracture.
Meaning excited.
Excited, but also concerned. Is because there is a very precarious blood supply to the scaphoid. And there is a area on the scaphoid which is called the dorsal radial ridge, and there is a branch of the radial artery that feeds through that dorsal radial ridge, and it's the main blood supply to the scaphoid. Now, if you break at the proximal pole.
And just to clarify, proximal is closer to the body.
Which is-
Distal is away from the body.
So the proximal pole is just
proximal
back
is
here.
closer to the distal radius,
distal radius.
and distal pole is away from the distal radius, closer towards the carpal bones and the thumb and the fingers.
Right. And so if you have a proximal pole fracture, well, now you have a potential loss of blood supply, right? So if it's displaced in any way, that's very concerning. If you don't, and if you don't,
And so are you saying that the distal pole has a more precarious blood supply? It has blood supply, but it's not as good as the distal pole has less blood supply than the proximal pole.
no. The distal pole has enough blood supply, so that should heal.
Right.
Generally, the waist will heal again as long as it's reduced, right? But the proximal pole is where we get concerned that there could be a loss of blood supply, and if it is not recognized early enough and not fixed surgically, then the potential is for that bone to die because it doesn't have blood supply.
And now, just to clarify why, and then I'm going to ask you that question. So vessels go from proximal, closer to the heart, and move distal. So can you explain to the viewers, why is it that the proximal pole has less blood supply than the distal? Because normally we would think blood supply goes in this direction, from the body out, but it's the anatomy, right?
It's the anatomy.
Anatomy of how the blood supply comes in.
Yeah, it's like a retrograde flow.
Right.
Essentially, is what's happening. And again, there's a main nutrient supply
That comes from the distal and then migrates proximally. So if you have a break,
yeah.
the classic break, and it's displaced even a little bit, like, I mean, with the scaphoid, even a millimeter is bad,
So
right?
Here's the thing.
Yeah.
If it's more than a millimeter displaced, automatically you need surgery, right? So one of the things that that typically is, if I see a scaphoid fracture on an X-ray, I usually get a CT scan to determine how displaced it is. Because if there's any bit of displacement on the X-ray, for sure it's more than a millimeter displaced. I shouldn't say for sure, but a lot of the times we do see that. And then,
Because an X-ray is two-dimensional, right? You see it in AP, and then you've got a lateral, and you can even have special scaphoid views, but again, they're two-dimensionals, whereas the CT is a three-dimensional reconstruction. You can even see the shape of the bone.
Again, and it gives us more
information.
More accuracy of measurement, right? Again, a millimeter is not much, right? So you want to make sure that your measurements are accurate if you're going to take somebody to surgery.
Right.
And so out of those different types of fracture patterns, waist fractures are still the most common fracture, where it's essentially in the middle of the bone, right? For an athlete, the likelihood is you'll fix any type of scaphoid fracture, right, to make sure that they get out onto the field and are able to recover from that. But a lot of the time, even if we fix it surgically, it's a longer recovery, just again because of that blood supply. Right. So usually the length of time you stay immobilized is going to be a few weeks longer than for some of the other typical
risk fractures
that we see.
Right.
Just because of that concern.
Yeah. And so the shape of it as well, like, it rotates in multiple orientations and directions and gives you the flexibility and stability of the wrist, right?
I mean, it articulates with so many different bones. Like many of the other bones have to act around the scaphoid. That's why I call it the quarterback.
Yeah. And that's assuming that you have just the fracture, not an associated ligament, cartilage, or other bone injury, which could also be possible.
Which is possible.
Right.
The wrist is very complex. You can see there's multiple different bones here that could be injured. And again, depending on the type of injury, the force, whatever mechanics went into the injury, you could have many different fracture patterns. But and the way to fix it is basically a intramedullary screw, central axis, and it has to be precise in order to make sure you have a biomechanically stable construct.
Right, because these bones are small. The outside, the cortical edges of the bone is not very big, so it has to be within
Yeah.
the cortical rim,
Right.
outside of the cartilage. And the reason is because you can't just plate it, right?
No,
Because
no,
it's
no.
all wrapped in cartilage.
Yeah.
It's that mobile that it's mostly cartilage on the outside because it's all articular.
Right.
Right.
And then for some of the proximal pole fractures, what we have to do sometimes is that we have to revascularize the bone. So basically, you put in a graft with a feeding with a arterial branch that basically you can feed into the scaphoid so that you can restore blood supply.
Yeah, and that sort of a microvascular revascularization is why I don't do hand surgery, because that's where I start yawning and get bored, because that's not as exciting. But
It's a great
experienced hand surgeons do that.
Yeah.
Hopefully, no one has to go through that.
Yeah,
so
hopefully.
so that's the scaphoid. It's a quarterback.
Yeah.
It's important, multidimensional. Rehab recovery again can take some period of time.
Absolutely. It takes longer. It does take longer.
So for him to get back into, let's assume
You're right.
it's the worst of the worst, but the best of the best fixation.
Fixation, yeah, absolutely.
So he's got that waist fracture. It's healed perfectly, 0 millimeters of displacement, and he's off to the races for recovery. Where do you think he'll land in terms of timeline, assuming best case scenario, earliest return to play?
Yeah, that's definitely a hard one. Say
I love putting people on the spot.
So again, I'm a little bit more conservative here, but essentially, if it's a waist fracture, it's non-displaced, we do have a central screw fixation, that is kind of best case scenario, right? So he's young, he's healthy. Maybe again, healing could be 6 weeks, right? And we start
For the bone.
For the bone itself, where I would feel more comfortable, you could start the rehab process, but in full gameplay, just getting your full mobility back, full strength back, I don't think that would.
And you want to
happen in 6
see
weeks.
that it revascularizes,
Yeah.
right?
I mean, if it's a waist fracture,
Yeah.
the chances that you'll have a AVN or
Avascular
necrosis is less likely,
Right.
That's more likely with the proximal pole fracture. But say it was like a waist fracture, again, non-displaced central screw fixation. That's best case scenario, and
Right.
probably could get out a little bit sooner. But
So are we talking 3 months, 6 months?
realistically, like in that best case scenario, maybe 3 months is early.
Early.
But
Yeah.
maybe it's possible.
Yeah.
Right, that I would just sort of say that. But like 6 months is probably typical for the average person.
Okay.
Right, yeah. I'm assuming this is like, we don't even know what type of fracture it was. So basically, if it was a scaphoid fracture, I would be very surprised if somebody was able to get back out 6 to 8 weeks. If it's it may be a different fracture. So again,
Maybe they used a bone glue tricorder and some,
Yeah.
They flew to China.
injected,
Yeah.
his bone marrow into it. Which again, there's a lot of technologies that may not be FDA regulated in outside countries. There's all sorts of treatment, right?
And it could have been a
Yeah.
distal radius fracture.
So
right?
yeah,
That's-
perfect segue.
Yeah.
So let's assume a distal radius. Now, if they expect him to be back in 6 to 8 weeks, we have to assume it's not a high-level intra-articular fracture.
That's what I'm assuming.
Yeah.
It might have been like an extra-articular Colles fracture, perhaps, right?
Mm-hmm.
And
And Colles is a term used to identify a type of fracture pattern that happened. It's outside the joint. And so typically, where would you mark, where would the fracture be on a distal radius?
I mean, metaphyseal
Yeah.
level below
Right.
the joint line,
Right.
essentially, right? So, it could again a Fuchs injury, classic mechanism of injury, and the likelihood is that even if it was displaced, it might have been minimally displaced. You put
Right.
a buttress plate with screw fixation to
Right.
stabilize that fracture, and again, still, maybe at 4 weeks you can start some gentle range of motion exercises,
Right.
right? And then advance range
Based
of
on that.
motion and strengthening.
But
is
if he had
tolerated.
something like a plate fixation for a distal radius, 6 to 8 weeks,
Again,
still sounds early to me.
It sounds
Yeah.
early to me too, but again,
Yeah.
we're making assumptions
Yeah.
on, based on what we see as mechanism of injury. We don't know what the
Right.
fracture patterns are. These are all assumptions.
Right.
So-
And then the other thing, minor avulsion propulsion fractures, little chip fractures,
Exactly.
all sorts of things. There's a lot that could happen.
Exactly.
That is for a 6 to 8 week return to high level play. Minor fractures, like maybe it's an undisplaced tubercle. It could be the radial stylo. It could be the ulnar stylo, assuming there's no TFCC or cartilage injury or
Other
anything like
ligamentous
that.
injury or something like that,
Right.
right? So again,
Yeah.
not knowing the exact injury, it's we're just prone to speculation here, right?
Right.
And we're just talking about the most common types of fractures you would see with that mechanism of injury. So
Right.
anyway,
So-
we wish Aiden O'Connor well and hope he gets back out there soon. And
Sounds good.
that's all I can say.
All right, we'll keep you updated.